Okay, so welcome back to this next video in which we are discussing rheumatoid arthritis and anti-rheumatoid drugs. Okay, so we're now in the process of discussing the pathogenesis of rheumatoid arthritis. So we've discussed that we're going to begin the pathogenesis from the arrival of these adaptive immune system cells. So we've seen that the subintimal layer of the synovial membrane is going to be infiltrated by these adaptive immune system cells. So T helper 1 cells, T helper 17 cells, which are both examples of CD4 positive T cells, they are going to come in and they're going to start releasing their characteristic cytokines, and the characteristic cytokine for T helper 1 cells is interferon gamma, and the characteristic cytokine for T helper 17 cells is interleukin 17. Okay, and these therefore are going to go up in the synovial membrane and also in the synovial fluid. You're also going to get B cells coming in, which are the precursors to plasma cells, and plasma cells are also going to be coming into the subintimal layer of the synovial membrane here. And the plasma cells are the ones which are going to be producing antibodies. Now, what are these antibodies directed to? Well, they're directed to some autoantigen that we don't yet, unfortunately, know. Some autoantigen that is present in the joints, basically. Okay, and we will discuss this autoantigen much more later because we do know something about it, but we'll come on to that later on. Okay, right, so that's where we've got to so far with this pathogenesis. We've got interferon gamma, interleukin 17, and also these immune complexes, which is when this autoantigen is actually bound to the autoantibody, and you've now got these immune complexes in the synovial membrane, extracellular fluid, and in the synovial fluid itself. And these three now, interferon gamma, interleukin 17, and immune complexes, these are now going to trigger the chronic inflammatory response. As long as these adaptive immune system cells are here and producing these three things, we are now going to have a chronic inflammatory response. So let me explain this. Okay, so we're going to chuck the interleukin 17 aside for a moment and we're going to concentrate on interferon gamma and the immune complexes. We'll come back to interleukin 17. Basically, interferon gamma and the immune complexes are both capable of activating type A synoviocytes, okay? So remember, in the intimal layer of the synovial membrane, you have these two types of cells, the type A and the type B synoviocytes. The type A synoviocytes are also called synovial macrophages, and remember, they have the job of removing gunk from the synovial fluid and destroying it, basically. So here, this is our synovial macrophage, an example of a synovial macrophage. And basically, synovial macrophages can be activated by interferon gamma and by immune complexes. Okay? Interferon gamma's main role, in fact, is to activate macrophages. Okay, and floating around immune complexes, macrophages have receptors for those as well, and they can activate these synovial macrophages as well. Okay, so both of those molecules, interferon gamma and the immune complexes, they are now going to activate these synovial macrophages. So what then is the response of the synovial macrophages? Well, the response is to start releasing a plethora of pro-inflammatory molecules, molecules that are going to cause the inflammatory response. Okay, so let me write some of these down, and I think I'll go onto the other page because I want this list where we've got room to actually write more about it. Okay, so far what we've seen is the interferon gamma and the immune complexes are going to activate those synovial macrophages. Now what we want to see is what are those synovial macrophages going to now release. Okay, and there's going to be a list of them now. Okay, so get ready for a list. We are going to go through what every single one of them does and we're going to build it into a picture, but for now it will seem quite listy. Okay, so number one, very, very important one. Okay, tumor necrosis factor alpha, TNF alpha. So I'll write down their names for the ones that it's not obvious. So TNF alpha stands for tumor necrosis factor alpha. Now, there are quite a few tumour necrosis factors in humans, okay? Tumour necrosis factor alpha is the most important one. So if you see someone just write TNF for tumour necrosis factor and not clarify which tumour necrosis factor it is, you can assume that they mean tumour necrosis factor alpha, because as I say, it's the most important one, okay? If they were talking about tumour necrosis factor beta or some other tumour necrosis factor, they would specify it. If they don't specify it, you can assume they mean tumour necrosis factor alpha. It's an incredibly important cytokine, okay? And remember, a cytokine is one of these molecules that's released by an immune cell and which has effects on the behaviour of other cells. Okay, so TNF-alpha. Another really important one is interleukin-1. Now again, there are lots of types of interleukin-1. We're not going to fuss over the different types of interleukin-1. In this case, we will write interleukin-1 and just mean all the different types of interleukin-1s. Okay, so IL-1 stands for interleukin-1. Okay, another really important one is interleukin-6. Okay, and if you're just going to learn 3 for rheumatoid arthritis, those are probably the 3 to learn: TNF-alpha, interleukin-1, and interleukin-6, particularly TNF-alpha and interleukin-1. Okay, but as we'll see right at the end when we come on to the biopharmaceuticals in our discussion of the anti-rheumatoid drugs, interleukin-6 seems to be quite important, more important than it's going to seem in my discussion of the pathogenesis, but we'll come on to that right at the end. Okay, then we have a molecule called interleukin-8. Now I just want to talk a little bit about the nature of interleukin-8. All of the other molecules that we see are going to be classified as cytokines. Interleukin-8 is a molecule that's released by immune cells, and it does affect the behavior of other immune cells. Okay, but it's going to be called it's going to be called a chemokine rather than a cytokine. Okay, now chemokines have a very special structure. Okay, all chemokines have a certain structure, and interleukin-8 obeys this structure, and therefore is called a chemokine. Okay, so just be aware that interleukin-8 wouldn't be referred to as a cytokine, it would be referred to as a chemokine, whereas all the other ones I'm going to mention, TNF-alpha, interleukin-1 and interleukin-6, and a few more that I still have, they're all going to be cytokines. Okay, so then the final one that I want to mention is what's called macrophage colony stimulating factor, MCSF. Okay, and these are all really important. They're all going to fit together to cause the pathogenesis of rheumatoid arthritis, which is why I'm listing them all out now. So this is macrophage, that's the M, and then it's colony stimulating factor, that's the CSF. Okay? Right. Okay, so those are molecules that are going to be released by our synovial macrophages upon stimulation by interferon gamma and immune complexes. And just to highlight this up, all of these 4, TNF-alpha, interleukin-1, interleukin-6, and macrophage colony stimulating factor, they are all cytokines, okay, along with interferon gamma and interleukin-17 that we've seen. Okay, so they're all cytokines. Right, okay, so the synovial macrophages also release some other molecules that are of note, okay, and the other class of molecules that I want to mention are prostaglandins, okay, and these are also very important to mention because the mechanism of the NSAIDs is going to involve the blocking of the production of the prostaglandins. Okay, so 2 key prostaglandins that these synovial macrophages are going to start producing are prostaglandin, PG, and then it's I2, okay, which is also called prostacyclin. So prostaglandin I2 has the privilege of having another name. It's also called prostacyclin. And then you also have prostaglandin E2. These are the 2 important ones that I'm going to mention. Okay, and we'll see what those do later on. Okay, right, so macrophages then, once they've been activated by the interferon gamma and the immune complexes, they're going to release this plethora of pro-inflammatory molecules, okay, tumour necrosis factor alpha, interleukin-1, interleukin-6, interleukin-8, macrophage colony stimulating factor, prostacyclin, and prostaglandin E2. Okay, now, We're going to start off by discussing tumor necrosis factor alpha and interleukin-1. Okay, these are the two most important ones in all of inflammation. These are so important. In fact, they're so important that they have a special grandiose name. Okay, these two together are known as the primary cytokines. Okay, they are the ones which initiate the immune response generally. Okay, and indeed that's what they're going to do here. They're going to initiate the inflammatory response. Okay, right, so previously what we had in our beginning, that beginning infiltrate that we had of the adaptive immune cells, as I said in the previous video, this isn't an inflammatory response yet. Yes, you've got adaptive immune system cells infiltrating into the subintima here, but at the moment it's not an inflammatory response. The joint is not inflamed yet. Okay, an inflammatory response really involves the innate immune system hugely. Okay, and these primary cytokines, tumor necrosis factor alpha and interleukin-1, they are now going to initiate the inflammatory response. So let's now discuss the inflammatory response. So these two together are now going to act on endothelial cells and initiate the inflammatory response. So, in order to have a decent understanding of the inflammatory response, we need to have a decent understanding of the microvasculature. So we'll start with that. Okay, so basically, microvasculature refers to the tiny blood vessels of the body. Okay, certainly not the blood vessels that you learn about in anatomy. Okay, it refers to the tiny little arterioles which supply capillaries and split into capillaries, and then the capillaries reconverge to tiny little venous vessels called venules. Okay, so I've drawn this here. So these tiny little vessels here in red, these are arterioles. Okay, and they are absolutely tiny, basically. Okay. Now, these arterioles are going to split into capillaries here, which I'll colour in turquoise. Okay, and these are even smaller. These, the lumen of these is pretty much a single cell thick, basically. Okay, so very, very small blood vessels. And then the capillaries are going to reconverge to the venule here, which I'll colour in blue. Okay, so we need to have a bit of a better understanding than just this, however, to understand the inflammatory response. Okay, we need to understand the structure of an arteriole, we need to understand the structure of a capillary and the structure of a venule. So I'll briefly draw this out here. Okay, so I'm going to draw what you would see if you took a cross-section down an arteriole, a cross-section down a capillary, and a cross-section down a venule. Okay, so let's start with what you would see if you took a cross-section down the arteriole. Okay, so here's the arteriole lumen. Here are the endothelial cells of the arteriole. Okay, like so, and I'll put their nuclei here. And they're going to be sitting on a basement membrane, so I'll put the basement membrane underneath them. Okay, so in turquoise here, this is their basement membrane. Now the basement membrane is a meshwork of extracellular matrix, basically. Okay, mainly collagen, but also other proteins such as laminins, and it's what the endothelial cells are going to be attached onto. Okay, that's what stops the endothelial cells falling into the lumen, basically. Okay, now in the case of arterioles, you then have another layer outside of the basement membrane, and I suppose I should just label these up. So this is the basement membrane, which will abbreviate down to the BM. Okay, and these are endothelial cells here, which will abbreviate down to ECs. Okay, right. Now, surrounding the basement membrane, you then have a layer of smooth muscle cells in the case of the arterioles. Okay, so let me put these here. So smooth muscle cells have these spindle shapes, like so. And the smooth muscle cells will be joined together to form circles, like so. Okay, and you'll have more than one layer of smooth muscle cells. Okay, so I don't mean to imply that there's only one cell, you know, that this layer is one cell thick. It will have more smooth muscle cells than just one. Okay, but they will be forming these rings around the arteriole lumen. Okay, and basically, if you can imagine what would happen if these smooth muscle cells all now constricted, or contracted rather, then their lengths would all decrease. And that would mean that the the circumference of this ring of smooth muscle cells would also decrease. And when the circumference of a ring decreases, that means that the diameter of the ring decreases, and therefore the diameter of the whole blood vessel would decrease, and that's called vasoconstriction. So basically, the smooth muscle cells here control the diameter of the arteriole. They control the size of the lumen of the arteriole. Okay, so SMC here is just short for smooth muscle cell. Okay, right, so that's the structure of an arteriole. Okay, and the key thing to understand is that it has this smooth muscle cell there. If we now draw what we'd see if we look down at the cross-section of a capillary, these are tiny little vessels. Okay, so drawn to scale roughly with this arteriole, here is the capillary, maybe 2 endothelial cells making up the entire circumference of the capillary, and the wall literally just consists of endothelial cells sitting on a basement membrane with a few cells surrounding them called pericytes. So I might draw a pericyte here. So this is a pericyte. Okay, and the pericytes do to an extent have a contractile function and can serve to narrow the lumen of the capillary. Okay, right, but the key thing to understand here is that really the wall of a capillary literally just consists of the endothelial cell sitting on the basement membrane. So the capillary wall is only consists of those two things, the endothelial cell and then the basement membrane, without these layers of smooth muscle cells surrounding you. Okay, then let's talk about the structure of a venule. So a venule is the same sort of size as an arteriole, okay, but it's thinner, the wall is thinner. It's basically got the same sort of a wall as a capillary, and you can think of these, as far as the inflammatory response is concerned, as just being giant capillaries basically. Here are the endothelial cells here, okay, and they will be sitting on the basement membrane here, like so. Okay, and these are going to participate in the inflammatory response just like the capillaries do basically. Okay, right, so now we studied the microvasculature, let's study the inflammatory response. Okay, so in our subintima of the synovial membrane, we will have these microvasculature blood vessels. We'll have lots of arterioles leading into capillaries, which then reconverge to venules. Okay, and we have now got tumor necrosis factor alpha and interleukin-1 going up in the extracellular fluid of our synovial membrane subintima. Okay, and these molecules are now going to act on the endothelial cells of these 3 blood vessel types. So they're going to act on endothelial cells all over the place. Okay, and basically what this is going to induce is it's going to induce communication between the endothelial cells and the smooth muscle cells that causes the relaxation of these smooth muscle cells surrounding the arterioles. Okay, specifically it causes the endothelial cells to start producing loads of prostacyclin, prostaglandin I2. Okay, and this prostaglandin I2 is what causes the vascular smooth muscle cells to relax. Okay, so that's one of the things that these 2 molecules now cause. They cause the vasodilatation, so I'll put that in this list here. So one of the things that these 2 molecules are going to cause is vasodilatation of the arterioles. Okay, that means now that more blood is going to be able to flow through the arterioles, and therefore more blood is going to be flowing through the capillaries, and therefore blood supply to the affected area is now going to go up. Okay, so we've raised blood flow, that's the first thing. Okay, in addition, the tumor necrosis factor alpha and interleukin-1 working on the endothelial cells in the capillaries and the venules are going to cause these endothelial cells to contract basically. Okay, so what you're now going to get is something called endothelial cell, which I'll abbreviate down to EC, contraction. Okay, so this means basically that the endothelial cells are going to pull back their extremities basically. So if I draw an endothelial cell here, okay, and I'll have its neighbour maybe here, okay, what's now going to happen is both of them are going to pull back their extremities. Okay, so this one's going to contract these portions here and pull away, and so same on this side, and so is this one. This one's going to pull its extremities back like so. Okay, so what this is going to go over to is something more like this, basically. Here's this endothelial cell now contracted, and here's this endothelial cell now contracted, and they'll still both be sitting on the basement membrane. And you can see now that we're opening up quite big gaps between the endothelial cells. Now remember, the capillaries in our subintima of the synovial membrane were already fenestrated, so they already had windows in them, they already had gaps in them, more gaps than a normal capillary would have. But now we're going to be opening up even bigger gaps, basically. Okay, we're going to be pulling the interaction between these neighbouring endothelial cells apart and opening up complete gaps in the walls of the capillaries, and this is now going to result in more fluid leaving the capillaries and also the venules. So this won't just be happening in the capillaries, it will be also happening in these post-capillary venules, as they're called, the venule that we've got here. Okay, and you'll now be getting more fluid leaving the blood and going into the subintima of the synovial membrane, and from there it will go into the synovial fluid, and therefore you're going to be getting edema basically occurring in the synovial cavity. Okay, you're going to be getting fluid accumulation. Okay, and this fluid accumulation that you have at this site of inflammation is what's known as an exudate. Okay, and that refers to the fact that this has a very special consistency. Okay, normal ultrafiltrate, which is the normal thing that the fenestrated capillaries allow the production of, does not contain many of the proteins that are in the blood. Okay, exudate, when you contract the endothelial cells this much and open up these massive gaps in the capillary walls and the post-capillary venule walls, you then allow proteins from the blood to leave the blood and go into the extracellular fluid. Okay, and when you get this fluid accumulation at this site of inflammation, which contains a lot of the proteins from the blood, that's called an exudate. Okay, so exudate doesn't just mean the fluid, it means the fluid containing lots of proteins. Okay, now what sort of proteins do I mean here? Well, I mean proteins involved in attacking pathogens. Okay, so proteins that are put into the blood by the liver and which are supposed to be delivered to sites of inflammation so that they can attack pathogens. Okay, so for instance, you're going to have complement proteins coming out of the blood and going into the extracellular fluid and therefore into the synovial fluid of our joint. Okay, and those are capable of attacking pathogens directly. Okay, you're also going to be getting the coagulation cascade proteins leaving the blood and going into the extracellular fluid. Okay, and also the synovial fluid. And those are involved in producing fibrin meshworks that can hopefully trap pathogens in basically at the site of inflammation. So all of these proteins coming in, they're designed to help you basically, they're designed to help conquer a pathogen. Of course the reality is in this case, in rheumatoid arthritis, there is no pathogen to conquer, but they're coming in anyway, they're part of the inflammatory response. Okay, so what is this then going to all lead to? It's going to lead to swelling of the joint basically. The amount of synovial fluid that you're going to have in the synovial cavity is going to go up and up and up, so you're going to get swelling of the joint. Okay, and that's not going to be helped at all by the vasodilatation that we've got, okay, because now we're going to be delivering more blood to the subintima of the synovial membrane, okay, and that's going to make the swelling worse, basically. Okay, in addition, the final effect on the endothelial cells that the tumour necrosis factor alpha and interleukin-1 are going to have is they're going to cause leukocyte extravasation. Okay, they're going to make the endothelial cells start recruiting white blood cells from the blood to the site of inflammation. Okay, so leukocyte is the fancy word for a white blood cell. Okay, and extravasation refers to the movement out of the blood into the extracellular fluid. Okay, so you're going to start moving white blood cells out of the blood into the extracellular fluid of the subintima, but then of course from there they can go into the synovial fluid itself. Okay, right, and that's the other thing that happens to these endothelial cells. So what sort of leukocytes do you actually bring in? Well, this is where some of these other cytokines become important. Okay, so interleukin 8 and interleukin 17 are very potent attractors of neutrophils. Okay, these make neutrophils come to an area. So basically, let me spell this out very clearly. If you have these molecules, interleukin 8 is a chemokine, interleukin 17 is a cytokine, high in a certain area, that area ends up with a huge number of neutrophils accumulated there, is the experimental fact, basically. Okay, so the leukocytes that you're going to start getting loads of being recruited into the joint are going to be neutrophils. Okay, now neutrophils have another name. Okay, they're also known as polymorphonucleocytes, or PMNs for short. Okay, so this stands for poly, and then the M is for morpho, and then the N is for nucleocyte. Okay, and they're called this because when you look at them under the microscope, they have a nucleus that has a very strange shape, basically. The nucleus, it has multiple lobes, so the nucleus of a neutrophil looks like so. Okay, it isn't the classical sort of circle shape. Instead, you have lots of lobes connected by these little stalks, basically. So this is the nucleus. It only has one nucleus. It's not a multinucleated cell. Okay, its nucleus is just split into these different lobes, like so. Okay, and basically, although having 3 lobes is the sort of most common number of lobes for a neutrophil to have, in reality, when you look at a histological slide containing lots of neutrophils, you can find neutrophils with 4, 5, 6 lobes, loads of different numbers of lobes, basically. So because the nucleus has so many different shapes, basically, that's why they're called poly, many, morpho shape, nucleocyte, nuclear cell, basically. So they're cells with many different shapes for their nucleus. Okay, so you're now going to start bringing in these neutrophils from the blood into the joint, basically. And remember, neutrophils were not there already. Okay, neutrophils are an innate immune system cell. They're not an adaptive immune system cell. Okay, so they're now being brought in at this stage. Okay, and most of these neutrophils that you bring in, they end up in the synovial fluid. Okay, so they come in through these blood vessels into the subintima initially, but then they end up dumped into the synovial fluid. Okay, so you get these accumulating in the synovial fluid. Okay, right. That's the inflammatory response then. Okay, we now want to look at some of these other cytokines that were released by those macrophages initially and see where their roles are. Okay, so the next one that we're going to turn our attention to is interleukin 6. So actually, maybe I'll just summarize where we've got to so far. So we've seen that TNF-alpha and interleukin 1 are responsible for producing this inflammation. Okay, they're responsible for producing the vasodilatation, the endothelial cell contraction, which produce the swelling of the joint. Okay, and they're also responsible for recruiting leukocytes into the joint. Okay, and the specific leukocyte that comes in the thousands is the neutrophil. Okay, and interleukin 8 released by the macrophages and interleukin 17 released by those T helper 17 cells are going to contribute to the arrival of the neutrophils into the joint. So you end up with loads of neutrophils dumped into the synovial fluid. Okay, right, and that's going to be chronic, basically. You're going to have this chronic inflammation. Okay, and that's a key word, I'll put that there. Okay, you're going to be getting a chronic inflammation because as long as those adaptive immune system cells are present in the subintima, you're always going to be doing this. Okay, as long as those adaptive immune system cells are producing interferon gamma and immune complexes, and also the interleukin 17, this is going to be ongoing. So you're going to have a chronic inflammatory response going on. The joint is going to remain swollen, it's going to remain infiltrated with neutrophils. okay, and it's going to remain with its blood vessels dilated, okay. Right, so now what we want to do is turn our attention to some of these other cytokines, okay, so I'm going to now turn my attention to interleukin 6 here, okay, but in fact, I think I'll call it there for this video, and we'll continue this discussion in the next video, okay, where we'll start by looking at what interleukin 6 does, and then we'll look at how this chronic inflammatory response and some of these cytokines being chronically high are going to lead to the destruction of the joint, okay, and it's going to involve not just the destruction of the hyaline cartilage, but also the destruction of the bone.